Hello and welcome to Physician Academy. Please visit us on our YouTube page and like our page. Please share this site with others and encourage others to participate. The more people involved, the better this site will be. Today we're going to discuss achalasia. This lecture is meant as an introduction to achalasia. Achalasia is a motility disorder of the lower esophagus. It affects the lower two-thirds of the esophagus. It's a loss of peristalsis, which is the contractile function of the esophagus to move things down the tube. It can occur at any age, but it usually begins between the ages of 20 and 60. Onset may appear like gastroesophageal reflux disease, also known as GERD, with gradual progression over months and years. There is an unknown etiology as to the cause of achalasia, but it may be related to a viral infection or autoimmune. Generally, it's a loss of ganglion cells in the myenteric plexus of the esophagus, which decreases esophageal peristalsis. Loss of peristalsis may lead to impaired lower esophageal sphincter relaxation. Lower esophageal sphincter relaxation or lower esophageal sphincter may have an increased resting tone. What are the symptoms of achalasia? The symptoms are generally as follows. There's a gradual onset of dysphasia, which is difficulty swallowing, for solids. Later, they develop dysphagia for liquids. Symptoms are progressive over years. Nighttime regurgitation of food is a common symptom. So how is achalasia diagnosed? The diagnosis is commonly started with history and physical. Another an additive to the history and physical would be a barium swallow, which shows an absence of peristaltic contractions during swallowing, or the classic finding, which is the bird's beak dilated esophagus. Why is it called the bird's beak? Is because it's dilated above the lower esophageal sphincter, and then there is a small, what appears to be bird's beak below, and that's a classic sign seen on barium swallow. Endoscopy is another important way to exclude other diagnoses that may cause similar problems. Manometry, which is done to measure the response of the muscles, so a contractile response of the esophagus. So manometry may be done to confirm diagnosis. It may become the preferred test over time. It's been shown shows an incomplete relaxation of the LES, shows failed peristalsis of the lower two-thirds of the esophagus. For the diagnosis of achalasia, it also must be differentiated from a carcinoma causing stenosis or peptic stricture. CT of the chest and abdomen can be used to diagnose cancer or tumor. And then you also must differentiate from patients with systemic sclerosis or Raynaud's disease, which can also cause other problems in the esophagus. So what are some of the problems or complications and issues with prognosis? Nocturnal regurgitation with aspiration pneumonia can lead to pulmonary complications. Cancer of the esophagus or other tumors leading to achalasia has a different prognosis depending on the treatment. So surgery, chemotherapy, or radiation therapy. So what are our treatment options for achalasia? There is no treatment or therapy that restores peristalsis. All the treatments are focused on decreasing the lower esophageal sphincter pressure and allowing food to pass. Medications are a good starting place to lower the lower esophageal sphincter pressure, to prolong the time between dilations. So medications of choice would be calcium channel blockers, nifedipine 10 to 30 milligrams, 30 minutes before meals. Nitrates are another option. Isosorbide dinitrate 5 to 10 milligrams sublingually before meals. These both help to lower the lower esophageal sphincter pressure. Other options would include Botox injections, or pneumatic dilation, which is where a balloon is placed and dilates the lower esophageal sphincter. And then finally, surgical manometry may be the final option. So this was our introduction to achalasia, and as more information becomes available or other people would like to add to this subject, we would welcome any additions and would be happy to add it to our lecture. Thank you for coming to Physician Academy.